Hello, I'm Carrie Levy. I am the palliative care section chief at the Rocky Mountain Regional VA.
And I'm Elizabeth Holman. I'm the palliative care psychologist at Rocky Mountain Regional VA.
And we are thrilled to be coming to you today. We would rather be there in person, but we are here on video to tell you a little bit about palliative care. We'll be speaking a bit from our experience at the VA, but hopefully this also extends to other palliative care environments. So we wanted to start by just talking a little bit about the overview of our time together. And you must know first that we are both Cherry Creek alums.
We're Bruins.
We're Bruins. So slightly different years, but we resonate a long time ago. But we both went to Cherry Creek, and we feel at one with you all today. And thank you for joining in. So what we're going to talk about today is we're going to go through the what, where, when, who, and why of palliative care. And we like to start with you live in a room, which we obviously aren't able to do today, but to have you just think for a moment about your thoughts when you think of palliative care or hospice. So we'll give you just a moment to process that and think about the words that pop into your head as you think about this. What we think about, what we do on a daily basis is symptom management, so relief from distressing symptoms. We talk with people about life and death and the normal process that death is as a part of life. We talk about how palliative treatments are neither hastening death or prolonging life, but really intended to manage symptoms and help people through distressing symptoms. We integrate a lot of different team members. So today, it's just the two of us, three of us actually. You'll meet our third team member as we go, but we have psychologists, physicians, nurse practitioners, social workers, chaplains, educators. We have lots of different people who come into this care team, and we'll talk about those disciplines as we go through. But the idea is that we're helping pull a team around people with serious illness and their families to help them through this time.
And I would just like to add that palliative, the word itself, for those of you who are word nerds, it comes from a Latin word that literally means to cloak, but the connotation is comfort. So you think of like a nice warm cloak on a cold day, and that's what palliative means. So sometimes we call ourselves team comfort. And I often, as Dr. Levy said, we have this long list of team members, but sometimes I just call us the full meal deal that's really focused on patients' comfort and their quality of life.
And sometimes people will say, well, isn't that just good medical care? And yes, but medical care has become so fragmented that it's hard for individual disciplines to focus on that whole person. So that's where we come in.
I think there's also something a little bit subversive about palliative care, and I say this as one of the non-medical professionals on the team, but a lot of times medicine in particular is really geared around healing and fixing, and which is totally reasonable, right? When I go to the doctor, I say something is wrong with me and I hope that you will fix it. But the reality is that illness and death are actually part of the human condition. And to have a specialty where death is not the enemy and where death is not treated as a failure is, like I said, it's a little bit subversive in the medical field. I think it's becoming less so, but it's an interesting place, particularly for medical professionals to be.
Yeah. And you're seeing our other professional here. Maybe we can move the camera down to see our friend here.
Tootsie, pause up. Tootsie.
There she is.
She didn't have a lot of room, but we have a dog on our team and she's awesome. And her name is Tootsie. She is another important part of the comfort team.
Indeed. So she will be here by our side, and we're very lucky to have her every day by our side. So um, we'll now move into where is palliative care, and you will all get slides with this presentation. You can follow along with the slides. So where is palliative care? It's in the hospital. So we do a lot of palliative care in the hospital. It can be in the ER. I actually had a meeting today about bringing palliative care consultation to the ER, and particularly right now with COVID, there are often these very intense discussions that need to happen quickly about whether or not people want to be intubated, whether or not they want life-sustaining treatments, and that needs to happen in the ER before they decline quickly. Certainly clinic, we have clinic all days of the week except for Tuesday, so we have palliative care in the outpatient setting. We do palliative care in the nursing home. Right now we're doing mostly tele visits to the nursing home. We do it at home. There's home palliative care, and again, we can do that via tele. Elizabeth does a fair amount of her work via tele, and so it's really everywhere. That's where palliative care is, everywhere. So when is palliative care appropriate? It's really appropriate for anyone who has serious illness. So that could be somebody who will not experience death for 3, 5, 10 years from now, but they have serious illness and they would benefit from symptom management now, talking about goals of care, what matters most to them. It also may be somebody that is really very close to the final months, days, weeks, hours of their life. So the critical thing in terms of when is palliative care appropriate is for anybody who has serious illness.
Anything that impacts their quality of life, really.
Mm-hmm. I have some slides in the slide deck that talk a little bit about life expectancy. It becomes important when you think about prognosis and when people are considering what matters to them. Often, if time is short, the things that matter most become very clear. And so we talk with people about how much time we anticipate they have left, and that often depends on how their functional status is, how active they are, and how much life they've already lived. And so in the slide deck, you will see average life expectancy by year, or excuse me, by country. And for example, in the United States, the average life expectancy is 79.1. Importantly, the United States life expectancy is not the longest. The longest is, any guesses? What country would you guess has the longest life expectancy? You've already cheated.
I cheated.
So it goes back and forth. Japan often has the longest life expectancy. Hong Kong, in the last look I did in terms of the tables that are available, 85.3 is the average life expectancy in Japan, and females enjoy a life expectancy of 88. So very different than the 79 in the United States, and you may be able to speak to why that would be. Infant mortality, some of the disparities we have in healthcare in this country, those things contribute to our shorter life expectancy. But certainly the amount of life you've lived contributes to the amount of life that we would expect to have left. And you'll see a table there also for men and women. So for example, if you are a woman and you are currently 90 years old, how many years would you expect that individual would have left to live? For a healthy woman, age 90, almost 7 years. So it's really quite
amazing.
something, isn't it? It really is. So it's
once you get to 90, you're just in the habit of living.
You're in the habit of living. That's exactly right. And then I have some details there just for those of you who have an interest in geriatrics about supercentenarians. So these are people who live to be 110 and beyond, and some details about those individuals. Because when you talk about life and death, you get curious about the outliers and how that comes about. So one of the things we often do as palliative care providers is we talk about advanced directives. So advanced directives have to do with, in advance of having a serious illness, having some sort of life-threatening event, what would you want to have done? And so you've likely heard of a do not resuscitate order. Those who have their heart stop can have an intervention where CPR is performed, cardiopulmonary resuscitation, and some folks would prefer not to have that performed. And in those cases, we want to make sure we've documented that preference and they have a do not resuscitate order.
I would just jump in and add that the terminology is changing a little bit more to a do not attempt resuscitation order. Dr. Levy can speak to this better than I can, but if all that folks know about resuscitation attempts is from watching TV and movies, you think it's like compression, clear, and the person comes back and says, "Oh, Marge, I'm so glad I didn't die." That is not the reality for the vast majority of people who experience a resuscitation attempt.
And so we like to have informed conversations about what the likelihood is for this individual of benefiting from that procedure, and make sure it matches up with what matters most to them in life, and facilitate an informed discussion about that. We also like to make sure we know who will make a decision for an individual if they are incapacitated and unable to make that decision. And so those types of documents, we try to make sure we get those in place for our patients. There's also a lot of discussion about the burden of illness and when too much, when treatment is too much. But we don't know. We might guess that someone wouldn't want the burden of, let's say, chemotherapy or radiation or some type of treatment when they're already very debilitated. But the honest truth is, until we speak to them and understand what their values are, we cannot know. And so we do have to have good discussions about those things. And there's some tools to help us do that. And certainly we spend a lot of our days talking about burden of illness and at what point, certain things become burdensome.
And that's something, interestingly, that again, the medical system is not, it's not always really well trained to talk about the burdens. People talk about the risks of a treatment. When anyone suggests a treatment, they're required to talk about what the potential risks are. And we talk about the benefits, what we hope will happen, but we don't always talk about burdens. Like, will you lose your hair? Do you need to come into dialysis 3 times a week for several hours? Does somebody need to drive you? What's the impact going to be on your family? Are there financial costs for this treatment that could be quite burdensome? So it's really it's a gift for us to be able to have conversations with people about things that are really important in terms of their quality of life, and often those things become pivotal in their decisions.
Yeah, and then the next topic is the providers of palliative care. So who provides palliative care? I alluded to this a little bit earlier, but we have chaplains, nurses, physicians, psychologists, social workers, physical therapists, occupational therapists, certified nurses aides. We have informal caregivers. Really, anybody who can be involved in the care team is or has the potential to be engaged in palliative care. We have in our palliative care village, we'll call it, at the Rocky Mountain Regional VA here in Colorado, we have 22 people who are involved in our particular team, between physicians, social workers, chaplains, psychologists, program support, and nurse practitioners. So we have a pretty large team. Now, not all those people are dedicated 100% all the time to the palliative care team, but are engaged in some manner in our team.
And it's worth noting that when I started here 10 and a half years ago, the palliative care team was Dr. Levy and a social worker named Clyde about half of the time, and a clinical nurse specialist named Jane full-time. And that was it.
Yeah, so it's grown. And the big reason for that is the VA in 2003 said every VA hospital needs to have a palliative care team. And so that was really forward thinking. That was in 2003, so that's almost 20 years ago now. And so because of that, palliative care has become integrated in really all facets, in surgical care and emergency room care and inpatient care and outpatient care. And so we've really had to respond to the need that's everywhere. As we mentioned in one of the early slides, palliative care is everywhere. And so we've grown to meet that need.
Thank God, because those people in that boardroom were.
So now we're going to talk about who receives palliative care. We touched on this a little bit. It's people with serious illness. But in terms of specific diagnoses, when palliative care first was started and when hospice was first started, largely people with cancer were the focus. The illness is often predictable, and so that seemed to fit nicely. Of course, over time, we've learned that illnesses, lots of different illnesses, will benefit from palliative care involvement in terms of managing distressing symptoms, trying to figure out what matters to people, helping support families. And so now, beyond cancer, we take care of all kinds of different diagnoses. So it might be chronic pain, it might be acute pain following a procedure, it could be a chronic illness of the liver or the lungs, or really any type of illness that is causing decline or symptoms that are difficult to manage.
And I think for me, one of the things that's really interesting about palliative care is that you do experience with so many different kinds of illness, and because the focus is on kind of the whole person, patient, rather than the specifics of one illness, if you're someone who wants that broader view, it could be a really interesting thing to consider.
Yeah, and we mentioned, why is palliative care needed? And Elizabeth talked about how sometimes the medical care is so focused on the cure and the medical treatment. And so our job is often to look at the big picture, help families, help patients look at the big picture and understand how this is fitting in, how this illness is fitting into their life, and how they might think about priorities in the face of this illness. So we as specialists, I've had friends say, you went through all that medical training and now, you really are not using all the technical stuff. I actually do get to use a lot of the technical stuff because I can understand the ventilator settings and what that means. I can understand the types of antibiotics and what that implies. I can understand a lot of the implications of what's happening. And so my internal medicine training I absolutely use when I'm thinking about palliative care. But what is it about the training of palliative care that makes that subspecialty unique? One is that we deliberately take time to sit with families, and that's one of the reasons I went into palliative care. I really struggled to be in a clinic where I saw, patients every 15 minutes. It didn't work well with my style and with what mattered to me as a clinician. And so I treasure the ability to sit at a bedside for an hour and a half if I have to. I probably make my colleagues crazy because I will sit there and sit there and sit there, but it's something I really value. It's also the experience of having really difficult conversations. A lot of people shy away from talking about how serious the illness is, and you've got a young, let's say a 28-year-old patient who's dying of cancer. Many people will, if you've read Being Mortal, lots of people will do everything they can to avoid that conversation, and it becomes often our job to have that conversation.
And people are so grateful. Every once in a while, people are really taken aback or they struggle, but most of the time, patients and families are so appreciative of, they know, or it's what they fear or what they think might be happening, and it's very hard for them to get good information. And so when people come in and they say, let's talk about what you're worried about, or we're worried about you, it opens the door for them to talk about what's really in their heart that they can't even talk about with their family members or their other providers.
I have a family member I was actually speaking to last week, and it's a year following the loss of her spouse, and she is still very troubled that no one mentioned that this was a very serious cancer. They talked about how it was unusual, but they never mentioned that it was serious. And so it was really not until weeks before his death that she found out it was serious, and she regrets not having that time to plan and really figure things out. So it's a gift. I think we think of it as a gift to give that information, assuming that the family wants it. And we, of course, talk about how much information they want to receive. And over time, almost every receive as much information as they have. So as far as palliative care programs, increasingly hospitals are recognizing, medical plans are recognizing that this is a really important part of care. As I mentioned, in 2003, the VA said every VA hospital needs to have a program, and now every VA hospital has a program, so it's really old news in the VA. And so the question is, well, okay, if everybody's doing it, what data do we have that it works? And the landmark study is one that was done by Jennifer Temmel, and it was done for non-small cell lung cancer patients. So they had metastatic lung cancer. So metastatic meaning it had spread outside of the lungs. And so these individuals got early palliative care or usual care. And outcomes were better for those who got palliative care. And a very unexpected finding in this study is that people actually lived longer. They never expected that finding, but it turns out that they did. And this has been really helpful to us because a lot of times people will assume that if you go the palliative care route, that your life will be shortened, but these data do not support that expectation. And so good care is good care, and people do better when they get good care. So we have a number of studies also that will be available in your slides about how palliative care does benefit folks. You'll also see some data about our consultation volume, and the point of those slides is that we initially started in the hospital and did all of our consultations in the hospital. We very quickly realized we needed to do outpatient consultation as well, and over time we've offered more and more clinics. We started with just a clinic where we'd kind of go wherever in the hospital the patient was, because they're sick. It was very hard for them to get back in for clinic. So if they were in the CAT scanner, we'd go to radiology and see them in radiology. And over time, we've gone upstream, meaning we've gotten to see them earlier in their illness, so they're not quite as sick. And so we can see them in a traditional clinic setting. We're also now with COVID doing a lot of teleclinic in their home, and on the telephone or on their phone via video. And so we do much, much more outpatient consultation now. So we do, maybe 20 or so inpatient consults a month, and we do 100 outpatient. So that's really flipped over time. And the ones we do inpatient are becoming more and more intense. They're more involved because once you do end up in a hospital, you tend to be pretty darn sick and things are complicated. So it's not as though that's become just easy breezy. It's not. But the work has really shifted in terms of the volume that we do. And importantly, when we have done more outpatient consultation, we've seen the number of veterans who die in the hospital really decline. And it's unusual now, actually, for veterans to die in the hospital if we've seen them. Generally, that's happening at home if we have been involved in their care early on. So as far as like a day in the life of a palliative care provider, we're going to go through just a few cases to give you a sense of what we do. So the first one is, we'll call him the frail go-getter. So again, these are in your slide deck, and you'll see this gentleman. He's a 94-year-old gentleman. He has metastatic, so widely spread prostate cancer. And what can happen is when the prostate cancer gets into a bone, then the bone becomes fragile and will just break, even though there's not a lot of trauma to it. Just the weight of his body broke his leg. So he had a fracture and was admitted to the hospital. He had what we'll call a difficult daughter. Sometimes difficult means they're good advocates for their loved one. But anyway, we had heard that she was stirring up a little bit of trouble. He had a lot of pain and fatigue,
And our job was to clarify his goals of care. We were asked basically to see what the next step would be, because typically older person breaks their hip, they go to a nursing home and they get rehab. But he has advanced cancer and he actually wanted hospice. But turns out the way the payment systems work, you can't do both of those very easily. You can't go to a nursing home for rehab and also get hospice. And so we were asked to step in and try to figure out how to honor his preference, take care of his daughter, and take care of his pain and clarify next steps. So, how would you approach this gentleman and his difficult daughter? We call Elizabeth when we have difficult family members because she fixes it. Yeah.
Well, one of the things that occurs to me, and I actually haven't read these studies, so
this is perfect. It's off the cuff.
But I think trying to sit down with a veteran together to ask, what's important to you right now? Are there things that you're worried about? How can we support you forward so that you can get the care that you need? And what do you want your last weeks and months to look like? Probably where I'd start.
Yeah. Yeah, and in his case, we did that, and it was clear that he actually wanted the physical movement that rehab would allow. He'd been a very active man in his life, and so the thought of doing rehab, as long as it wasn't painful, was appealing to him. And so we were able to work with the nursing home to provide delicate, if you will, therapy so that he could move and get the exercise that he wanted to, but also to manage his pain very carefully. So what we did in his case is palliative care saw him as opposed to hospice, since hospice wasn't an option, while also getting rehab therapy in the nursing home. And then as soon as he had gotten through his, we won't go into all the nuances of Medicare payment, but once he'd gotten through his Medicare days in the nursing home, then he was switched over to hospice care. And they really focused on his pain management and helping him through that last phase of life. Turns out the daughter wasn't difficult at all. She was really just trying to figure out all the details that come with acute illness as you're caring for an older parent, which is really, really hard. There's a lot going on at that phase of life, and often caregivers will feel quite overwhelmed, and it can come off as being difficult, but really what it is trying to gain control over some pieces of the situation.
Our social workers are such an important part of the team. And I guess I think for me, that's another thing that I love about palliative care, that we work together as a team so closely with tremendous respect for each other's expertise and an ability to, we stay in our own lane, but we also can step into the other person's space if we need to, if they're not there, but we also know when to say, like, okay, I can tell you there's some benefits, I'll go get the social worker to really walk you through what that looks like. And people are so grateful for that. I think the other thing I would say about that case study is that people sometimes hear palliative care, and for when they think it's the same thing as hospice, they'll say, oh, we're not ready for palliative care because they think palliative care equals hospice equals go home and die. And they worry if we get palliative care involved, we'll just shove them into hospice. But the reality is we advocate really hard for patients to get the thing that they want. So in a case like this, he wanted rehab. He wanted to do the hard work, and we said, fantastic, let's make that work.
Absolutely, and that's a great point. That distinction between palliative care and hospice is really important. It's actually pretty easy. Palliative care, as we've talked about, is for people with serious illness at any phase in a disease. Hospice is for someone who has a life expectancy of 6 months or less. And so if the disease takes its expected course, that has to be certified by 2 physicians. And that's really the distinction. So if life expectancy is 6 months or less, that individual would qualify for hospice. If it's longer, then palliative care would be more appropriate. So our second case study is a mother. So 36-year-old mother who had multiple hospitalizations for a progressive breast cancer, and she was short of breath. We had made a connection with telehealth for some chronic pain management. We got her advanced directives in place, but the thing that was most distressing in this case was the support for her children, small children, who were really her major concern.
So we arranged for support for the mother and for the children. We're providing that here, and sometimes it's out in the community. But supporting them and helping them understand in an age-appropriate way what was happening was a really important part of her care.
And interestingly enough, often Tootsie, who is sound asleep right now, will be a wonderful, she will identify, the person who needs it most in the group. And we really rely on her to help provide for that just-in-time support also.
Okay, and we're just going to finish up now with two more cases. One was a 28-year-old male we cared for, and of course, young patients are tough. And this gentleman had advanced cancer. He'd been admitted multiple times this past year and had severe pain. So our role in his case was to help with pain management, help with shortness of breath. There was an extreme amount of family conflict and complication. And this happens, right? This happens, and end of life sometimes brings families together, and sometimes it just heightens all of the problems that have been going on for years. And in this case, it certainly was not helping. So I mentioned that young patients, it's often harder, and age does matter. It just does. So in this case, really all of the team members were needed. We needed our social worker to help with some of the legal things that were happening. We needed Elizabeth to help with his coping and management of the disease. We needed our physicians to assist with symptom management. And it was really all hands on deck.
And the chaplains.
Thank you. The chaplains,
really
yes.
important. Both, providing support, the chaplains, and really all of us provided support to his parents when he was sick, and provided support to them after the veteran died, and even things like making sure that one parent who wasn't present when the veteran died, that he was able to have some time with his body afterwards. So kind of the full spectrum, and helping them navigate, just the difficult family issues that arise. It definitely was a team effort.
Yeah, and then finally, we were going to talk about, and this is a pretty typical day, right? I mean, these are sort of the cases that we see, and the things that we help with. I think a lot of times we're also helping the teams who are caring for patients, because there can be a lot of moral distress in provision of care. And this last case, it was a 77-year-old gentleman who had been on dialysis. And the dialysis team was conflicted because he wanted to stop dialysis. And generally, when people stop dialysis, life expectancy is quite short, measured in days to weeks. And so it's a potentially very final decision. Sometimes we have veterans who stop dialysis and they do fine for quite some time. But in general, we need to prepare as though the time will be very short following the cessation of dialysis. And so in this case, they wanted to make sure that the decision being made was indeed a well-considered one, and they cared about this patient, and they were having some anticipatory grief themselves. And so in this case, we talked to the patient about his goals and what dialysis meant to him and how that was impacting his life. the life of those around him. And his perception was that really everything revolved around dialysis. And there's a lot of complications often with dialysis. And really that he was only living to be dialyzed, and there wasn't a lot beyond that. So he felt like he'd done what he needed to do, and it was time to go ahead and stop the life-sustaining treatment and have a natural death. So we provided home services. We put some home services in place so that he could be at home for that final phase of life. Certainly, counseling was provided to his family members and to the team who cared for him. He was a very spiritual man, so our chaplains were integrally involved. And then we provided the bereavement following his death to family. We have a very special opportunity here at the VA. We have regular bereavement services, memorial services, and so families can participate in those. But then we also have individual services or not services, but individual support for family members as well. So that's how we handled that particular case.
No, actually, but just one other thing I'll throw in about one thing that's special about working at a veterans hospital is that in cases where a patient dies in the hospital, a lot of our staff are veterans, and it's very important to us to recognize the veteran service. And so we do something called the final salute, where staff are notified, families gathered, and the body is draped with a flag. They're put on a gurney, and they that all the staff lining the hallways are called to attention, and those who are veterans salute, and those of us who are not do our hand over our heart, and they play taps as the body is taken out to the morgue and the family follows. And our leadership makes it a point to be present, and it's extremely meaningful and just a really, it's just an important way to thank veterans who've given so much to our nation. So obviously that's not something that occurs in every hospital, but it feels like a real gift to us here.
And we talked through these cases. We talked about the older gentleman who broke his hip, and the younger mom whose kids were needing some support, and the younger veteran, and gentleman who was stopping dialysis. And sometimes I'll tell people what I do, and they say, "That's terrible. How can you do that? That sounds awful." It's amazing. It's amazing work because those of us who find ourselves in this work value these meaningful moments we have with families, with staff, with each other, with our patients. And I don't know that we could do anything else after we start this work, because it's intense. It's definitely intense. It's also so meaningful, and we don't find ourselves wondering, did I do anything today? Yeah. Exactly.
All right, and I'll introduce, in case she wasn't visible, Tootsie Lap. Tootsie Lap. Good girl. So this is Tootsie. She's our facility dog here, and that's a subject for a different day. But the short version is that she comes to work with me every day. She goes into the hospital and sees patients as long as they're not in the intensive care unit or contact precautions. And she provides an enormous amount of support to our team and to the staff, as well as to the patients and their families. And so if you ever have an opportunity to have a canine member on your team, we commend that to you.
She is quite special, that is for certain. So we thank you for your time today. We are really disappointed we can't be there in person to talk to you and to hear your questions and thoughts about things. But we hope that you are taking good care of yourselves during this distressing time. And if you have questions, you are welcome to send them to us to email. And all you need to do is reach out to your course director, and he will forward those on, and we'll be happy to reach back out. So,
and know that there are at least 4 Cherry Creek graduates
that is true
here at our VA medical system. So yeah, there's lots of exciting things ahead for you. We're so appreciative that you let us be part of this. Take good care of yourself.
Thank you again. Bye-bye.
Bye.
Can you wave, Toots?
No.
She's very busy right now. All right, take care. Thank you all.
Thanks. Bye-bye.
Bye-bye.